Hi there, everyone. I hope everybody's doing okay. I think we'll just give folks a couple more minutes and we'll start promptly at 12:05. Is that Tom there? It's quite the background. I think you're on mute.
Hi, Tom.
Good morning. Good afternoon.
Hi,
Wow, what a
Tom.
crowd.
Afternoon.
What a crowd. Hi,
Love
Tracy.
the background, Tom.
Oh, thanks. I have several. I can switch them out if you want to.
Is that the one you use
Whoa.
with CGHI?
No, I have a different one for UCGHI.
Hey, Trace.
Hi. Good to see your faces.
Yeah, you too.
Hi, Dan. Good to see you.
Good to see you, Tom. So nice to have Tracy back. For the students, Tracy's been on leave, helping care for her children. But I think she secured some help in the form of daycare 2 or 3 days a week. So she's able to join us on a part-time basis, and we're excited to have her back.
Yeah, I'm looking forward to reconnecting.
I expect she's excited to be back too.
Definitely.
It's a lot of work, huh?
Yeah.
Homeschooling and working.
It's a juggle.
Yeah. Jeff, my husband, just had knee replacement surgery. So I understand the juggle. I'm not juggling his rehab as well as everything else, Not nearly as difficult as for children, though.
Well,
Yeah.
depends.
Exactly. We won't go
Wishing
there.
him a speedy recovery.
Thank you. I will.
Well, in the interest of time, so we can start promptly with your presentation at 12:05, Tom, I just want to give a couple of updates and briefly present you. The first update for the students is that we have had 17 of the second-year students apply for the pathway this year, which we're very excited about. The majority participated in the global STTP, but we also had a few that didn't, and we're excited to have them join us. There are also a few that have been particularly interested in local, global, and equity issues, which is certainly part of the evolving Global Health Program initiative, as well as the pathway certain interest and what it encompasses. So for the students, I think I've reached out to all of you, and Tracy may be reaching out to you as well to touch base to see how we can help mentor you. And Tom, you have been a great resource for us. I think you're officially the director of the social IRB, is that correct? Or co-director?
It's called South General. I'm the chair, South General IRB. We get a lot of health services, most of the health services and international work. Yeah.
So we're very fortunate to have you leading the discussion today about the IRB. In the way of background, for those of you who haven't had a chance to hear Tom either speak at the Selective or elsewhere, he is a huge mentor of mine, brought me to join the predecessor to the Global Health Program, the Center for World Health, and currently directs the UCFC Global Health Institute, and was former director of the Center for World Health. He has been very active in the realm of HIV research, and at one point I think was the most funded social sciences researcher in the country, and continues to be very active in this research and well-funded, and has been just an outstanding mentor to our students who have done Pathway and other projects with him, as well as a great mentor to faculty as well. So we're excited to hear about your insight into the Institutional Review Board, probably with more of a focus on social science work. And look forward to the discussion.
Oh, thanks. So this can get really dry, you know, sort of the IRB and the procedures and yada, yada, yada. So I think if you have questions as we're going along, please ask them. I'll be showing some slides along the way, so I may not be able to see you raise your hands. So just interrupt and just say, I have a question. And I think, or if you have an example that you want to run by me, just let me know. I think it goes a lot better. So I wanted to start just briefly talking about what I'm doing currently, in case any of you are interested in working on any of the projects that I'm working on. So let me share my screen. First of all, let me get rid of my beachy background, and so you can see the screen okay. Okay, there we go. Now you see where I'm, my natural habitat. And so let me now share my screen, and so you can see this. So as Dan mentioned, I'm the director of the University of California Global Health Institute, which is a system-wide global health institute. So if you have interests, feel free to reach out to me if you have interests that sort of go beyond UCLA, and you might want to reach out to somebody across the system. I'm in touch with a lot of what a lot of people are doing. So in terms of my own work right now, I have this one study is actually in its 6th year, so we're in the process of winding down. It was extended because of COVID and difficulties in collecting the inline data. But this is called Zwakala and Dota. And you know, there's this observation that men in sub-Saharan Africa lag in terms of testing, but also access to care. As someone put it, men see a physician, they see a pediatrician and a geriatrician, and rarely go in between unless there's some acute problem. So this is to really understand how we can both reach men for testing, but also then for men who are HIV infected, get them engaged in the care process. It was a cluster randomized study and then an individual randomized study. The cluster randomized study was very successful. We were very successful in reaching over 80% of the men in each of the communities with testing, and now are working on the linkage to care part, with the endpoint being viral load suppression. Also with Devorah Joseph Davy, we're evaluating pre-exposure prophylaxis in pregnant women in South Africa. This is with colleagues at the University of Cape Town. We're recruiting a cohort study of 1,200 pregnant and breastfeeding adolescent girls and women, and evaluating both uptake and who initiates, as well as retention and adherence, measured through dried blood spots and analysis of tenofovir in the blood. Also, we've had a long established relationship with Malawi, actually about 15 years now. And with Kate Devil, we're looking at HIV self-testing and also index partner HIV self-testing. That is, women, when diagnosed with HIV, are then offered test kits for their male partners. And we've published on that very successfully. Men will take up testing. Again, it's the linkage to care piece that is really quite difficult. Malawi, by the way, is considered one of the success stories in HIV in Africa. This little country, 11, 12 million people, about a 10% HIV prevalence, but you can really get things done. And they've just been on the forefront and have reached their 90-90-90 goals. 90% of the HIV infected population tested, 90% of them 90% of them aware of their HIV status, 90% of those who know their HIV status engaged in care, and 90% of those virally suppressed. And now they're working to 95, 95, 95. And then I have some foundation funding from the Conrad Hilton Foundation to do early childhood development training for HIV infected mothers. And then we have funding from Charlize Theron and her Africa Outreach Project, leadership training for South African youth, particularly women, young girls between high school and tertiary education. These are women coming quite often from remote places, poor places, And so going into tertiary education can also often be a challenge. And this is to help them do best. So now let's turn to the issue of ethics of research. So ethical violations have a long history. I always like this example. The King of Spain was concerned because his armed forces in the New World were catching smallpox, and there was no way to protect them against smallpox. So what he decided to do was engage orphans. He emptied some of the orphanages, put them on a boat, gave the first young orphan cowpox. Then as the pustules appeared, they scraped them and preserved them. And then that orphan gave smallpox to the next orphan, and they kept going down the line. So by the time they got to the New World, they had a bunch of samples of cowpox, and they could vaccinate their soldiers against smallpox. Of course, this isn't the last egregious ethical violation. I mean, we're all aware in this century, Tuskegee, really sort of stands out and is the prime example of medical mistrust, where what started as a natural history study of syphilis in Tuskegee among African-American men turned into a tragedy, because when it turned out that penicillin was a very effective treatment against syphilis, these men were not told about that because they did not want to interrupt the natural history of the disease, of their studies of the disease. Probably one of the most egregious ethical violations in U.S. history. And this was done by our Centers for Disease Control and Prevention, which is now actively engaged in the fight against COVID, except when the medical folks in the White House, Melania and Donald, decide to intervene in other ways. It makes me livid what they're doing. It's medical, it's really medical malpractice. Okay, I said it. Now I feel better that I've said something, but nonetheless, it's really, really bad. So the topics I thought that we would cover today are: who are human subjects? What is risk? And then there are different kinds of reviews. There's exempt, there's expedited, and then to talk a bit about informed consent, HIPAA, and how HIPAA weighs in when we're doing human subjects research, international, and the process. And again, if there's anything else that kind of comes to mind, please raise it. Or if you have questions about an example that you want to talk about. Let me get out of this and go to, I think I queued everything up I wanted to queue up. So first, let's go to, get rid of that, get rid of that. I was on My UCLA Health looking at some test results. You don't want to see those. Let me go to, so the beginning of all of this was the Belmont Report. And so it was created by a national commission, and it was actually issued, it's kind of interesting, September 1978. So I got my doctorate in 1977. So we were operating prior to this time without established principles and without established guidelines in terms of human subjects. So all of this is relatively recent. There's a whole series of egregious experiments. You can Google the 10 most unethical experiments in history. And of course, the worst of the worst had to do with the so-called medical experiments in the concentration camps in Nazi Germany. And I say so-called because they really weren't experiments at all; they were torture. But it really sort of spurred the discussion of ethical principles and guidelines for research involving human subjects. And they talk about the Tuskegee syphilis study and so on and so forth. But the big news is the three principles that for human subjects, and one is respect for persons. So you have to protect the autonomy of all people and treat them with courtesy and respect. That means they inform consent. You can't study people without their consent. And that means they need to be fully informed of what it is you're going to do and decide whether or not they want to participate. Sometimes I'm on Facebook, sometimes a little too much because it's not so great for my mental health. But you sort of see some strings of chatter about, well, let's just test the COVID vaccine on prisoners. They're in prison anyway, and there's a lot of COVID in prisons. Let's just test it on them. And there is a history of prisoner experimentation, but prisoners are a protected class of individuals, and it's considered coercive. So autonomy has to be fully autonomous. We get into this sometimes when we're also looking at protocols where physicians are recruiting their patients. And the patients, in fact, may think that the physician wants them to do this, or that there is benefit, or if they don't do it, they're not going to be able to be treated at UCLA or wherever you're seeing them. And so we really want to protect people's right to make informed consent. Beneficence, do no harm, while maximizing benefits for the research project and minimizing risks to the research subject. So there has to be a ratio of risk-benefit. Most of the research, most of the health services research, the international research that we see is minimal risk. And minimal risk is defined as risk that you would experience in everyday life. So there may be a little anxiety, or getting your blood drawn may cause a bruise, or there's other risks associated with that. That's minimal risk. And most of the work you're going to be doing is minimal risk. The risk-benefit ratio evaluation changes as the risk increases. So with the COVID vaccine trials, these are challenge studies. That is, individuals are recruited, they're screened to be healthy, but they're challenged with the COVID virus. And they have to agree to that. And that's why there has to be a balance between the risk and the benefit to the individual, not only to society, but to the individual. And that's based on the phase 1, phase 2 data that demonstrate that there could be benefit from the vaccine. And then justice. Reasonable, non-exploitative, well-considered procedures are administered fairly. And it's a fair distribution of costs and benefits to potential research subjects. You cannot do a study in Africa if the intervention is only going to be applied in the United States. And we've run into that in HIV. If you're going to do a study in Africa, Africans need to benefit. And if you're going to do a study in the United States, you must ensure that everybody in the population will have equal access. It can't just be whites. It needs to be African Americans. It needs to be Asians. It needs to be Latino. So these three principles form the core. And then these are the essential reference for institutional review boards. Now, IRBs weren't, hi Kate, I haven't seen you in a while. I don't know many of you, but it's great to see you. IRBs were not just devised to torture you or make life difficult. IRBs are federally mandated review boards. Every institution receiving federal funds in the world must use a federally chartered IRB. And essentially what we're saying is, if you've gone through an IRB process and the IRB signs off on your protocol, then it is considered to be an ethical protocol as long as you follow the protocol. And it does protect you against complaint and against potential litigation, because the institution is saying, we are trusting you as the PI to do this research as you said that you would do the research. So let me just stop there and ask if there are any questions, comments at this point. Anything anybody would like to ask? All right. Somebody chatted something. Please turn on your videos if possible. Yes, thank you, Dan. It's a little hard for me to follow the chats and the hand raises. So as I say, just speak up if you would like.
So
Tracy, I think, has a question. And also for the others that don't want to speak, you're welcome to also just chat a question and we'll try to capture it and ask it for you.
Tom, I don't know if you have any memory of any projects that you've received at the IRB that were kind of, you know, borderline, where there were some gray areas or some questions, but I always find those kind of interesting because a lot of us that submit to IRB, it pops back to us where it's kind of pushing us a little bit further on things like whether or not the participants are anonymous, whether or not, you know, like just these gray areas where it could have some potential harm, but we may not think about it right off. So, because the examples that you see in the literature and that we've talked about are obviously egregious, but a lot of people may come forward with a project that in their mind seems ethical, but the IRB is really looking at very kind of specific, more subtle kind of incidents.
No, you make a very good point, Tracy. Most of the stuff that comes through, you know, it's okay. I mean, it's reasonable stuff. It's not, people aren't going to go off and do terrible things to people and, you know, violate their rights and so on and so forth. It's really much more in the gray area. So kind of figuring out where we set our compass. Probably a couple of examples. One is I'll use this as an opportunity to make a very important definition. What is human subjects research? It's a human subject is a living individual about whom an investigator, whether professional or student, conducting research obtains information or biospecimens through intervention or interaction with the individual and uses this information and, very, very important, generates identifiable private information or identifiable biospecimens. So it's got to be identifiable. So, example, somebody's interested in doing a bit of health services research. They are, say, interested in a particular disorder, the prevalence of that disorder, the risk factors for those disorders within the UCLA patient population. Well, the CTSI has a process whereby you can request information from the electronic health record, and they will retrieve that information and de-identify it so that you get a set of de-identified data. A lot of questions around that, whether it's truly de-identified. That is not human subjects research. That is exempt. Now, in the UCLA process, you cannot self-exempt. You need to submit an application to get an exemption. But that's a good example. That kind of situation comes up all the time. Another sort of borderline situation is I want to study XYZ disease in my patient population. And I want to recruit my patients to participate in this study. We get a little squeamish about that and prefer a little bit of distance. And that distance being, you can do the study, obviously, and clinical research is important. But rather than pitching to your participants, to your patients, you can give them an information sheet And if they're interested, they can make a call or go on a website. So we like a little bit of distance there, so it doesn't get coercive. Another example. I don't want to reveal anything, but a study's being done of COVID symptomatology, and the flyer that they submitted was, I'll paraphrase this, but it was something like, a lot of people are suffering from COVID these days. Do your part and participate in this study so we can get a better understanding of COVID symptomatology. No. It's no. Here's an opportunity to participate if you want to, not do your, don't shame somebody into participating in your study. So that's kind of another one. I think questions also can come up. So in the federal government and the NIH regulations, 18 is considered adulthood. If you want to study individuals below the age of 18, typically you need parental permission. However, there are exceptions to that. Say, for example, you're really interested in something in the sexual and reproductive health arena, or we've seen studies like this of transgender youth and young people sort of struggling with their sexual identity. If they have to ask their parents, they're never going to participate. So you can sort of think, okay, well, maybe we can study people below the age of 18 on these sensitive topics and not ask their parents' permission. Other examples include youth who are part of the criminal justice system and who may be wards of the court. And again, may need to go to the court, may need to appoint a monitor, but it is possible to study these young individuals without parental permission. Now, when you go internationally, if it's NIH funding, US federal rules apply. If you're not, a protocol came through the other day where it's not NIH funding, it's foundation funding. So the study is being done in Kenya, and Kenyan law allows down to the age of 16. They consider people over 16 an adult. So in that case, Kenyan law applies. But if it were federal funding, it would have to follow federal guidelines, US federal guidelines. Does that help you a little bit? Yeah. Okay. Other questions or comments? Questions? Are you all just enthralled by this topic? No, as I say, it can get a bit dry. It's actually quite interesting when you sort of tease through it. Now, the other thing I want to show you, submit a great idea. So let me find this website. So this is the website, UCLA Office of Human Research Protection Program. So this is kind of everything you need to know is on this website. The other thing is the staff of OHRPP are really, really helpful. When I first came to UCLA, the attitude was we need to protect the public against the nefarious doctors doing research at UCLA. And it was like the faculty were the enemy, and they were protecting against us. The whole thing is shifted so that the Office of Human Research Protection is user-friendly at this stage of the game. And if you have questions, you can ask them. The person who you will most likely interact with, his name is Paul Lillig, Lillig, and his email is plillig@research.ucla.edu, and he is an indispensable resource. And if you have questions, you can just ask him. So you go to this web page, welcome to OHRPP. Here are the COVID stuff. And then you sort of look at for researchers and you see everything that you need to know. So assessing risk and how risks are minimized and how risk must be reasonable in relation to anticipated benefits. You know, they define risk, and then they, as I say, most of the work you're going to be doing falls in the minimal risk arena. It's not greater in and of themselves than those ordinarily encountered in daily life of the general population. It can, even though maybe say you're just studying a particular population, but you're interested in certain mental health variables. And we get this quite a lot, where people are interested, say, in anxiety and depression. And then you use some of the common depression scales. And they ask questions about suicidal thought. And then it becomes more than minimal risk, because if somebody divulges to you that they are severely depressed and or have thought about ending their own life, then you have information that you need to do something about. And what we usually require in those cases, if you're asking about severe depression, usually we say you need to provide resources for people. But if we're asking about thoughts about ending life, then you need to have a suicide plan. And there are directions on the OHRPP website for that. As I mentioned, prisoners, you know, everybody wants to do, there's a lot of, well, let's just study prisoners. They're a captive population. And it's somewhat different than for non-institutionalized adults. A risk is minimal when the probability and magnitude of physical or psychological harm that is normally encountered in the daily lives with the routine medical identity examination of healthy persons. Okay, so, and then they describe the kinds of harms, social and economic harms, privacy risks. Obviously, we place a lot of importance on confidentiality. And in the informed consent document, you promise people confidentiality. And there are standards in terms of how you guard your data against breaches of confidentiality. Let's go to this one, the levels of IRB review. So I mentioned before exempt research. And these are examples, anonymous surveys or interviews. You put something up on RedCap, you put it out to the world, you want to get responses, you're never going to know who these people are, the data are automatically de-identified. That's exempt. Passive observation of public behavior without collection of identifiers. Retrospective chart reviews with no recording of identifiers. Analyses of discarded pathological specimens without identifiers. So those are examples of exempt research. And as I mentioned, if you query the electronic health record and you get the data back without identifiers, that is exempt. Now, Tracy, you asked about a sort of a sketchy example. So very early on in the COVID epidemic, there was a group within the health system very interested in trying to identify and track down COVID exposures, particularly among health staff, among the first line health staff. And so they were collecting data from them, but they were also collecting data from the electronic health record about the patients to whom they might have been exposed. So all of they were doing this as a part of their routine job. This is what they were asked to do by the health system, so that they could begin to quantify risks to healthcare workers of COVID exposure. They then took that information and prepared a report for publication. Now, we got a little caught up because the same people analyzing the data and doing the report were the same people who had access to the identifiable information. But they assured us that they created a de-identified data set, and that's the data set upon which they did the analysis for publication. And so that was considered exempt. So that's kind of an interesting example there. A lot of work that you're going to submit is going to be expedited. And by expedited, what usually happens here, the process sort of works like this. You go through the whole process of filling out the IRB application. It then goes in to staff. Staff look at it. They send it back to you with questions and things that need to be corrected and things that don't match and where you've checked the wrong box and sort of all that stuff. So once they've done that, then it will come to me or somebody like me. And to see if it can be expedited, if it meets one of the expedited categories, and or if the risk benefit is reasonable. We might find a few things wrong with it, or a few things that need correction, or maybe we're not happy with the informed consent, whatever. It goes back to you, you fix it, it comes back, everything's lined up, and we approve it. So it doesn't have to go to the full board. You see some of the examples there: surveys and interviews, a collection of biological specimens, collection of blood samples, studies of existing pathological specimens with identifiers. A lot of times, qualitative research, focus groups, one-on-one interviews, pilot studies will fall under the expedited category. And you can see here, you can click through to the expedited guidance and all of the categories that qualify for expedited. Oops, I think I hit the wrong one. Okay, then for us, a small group of studies come for full board deliberation. And you can see the examples here: clinical investigation of drugs and devices, studies involving invasive medical procedures, longitudinal interviews about illegal behavior and drug abuse, treatment interventions for suicidal ideation and behavior. The other group that comes are studies of vulnerable populations. These would be studies of prison populations, studies of various offender categories. We see a lot of studies involving, there have been various experiments in the state of California about different prison diversion programs or drug treatment diversion programs. All of those because you're dealing with an offender population, which is considered a vulnerable population. Studies of pregnant women often have to come for full board clearance. These are a smaller subset of studies, but studies that are considered vulnerable populations or where there's particular concern about informed consent. So as I say, most of the work that you're going to submit will probably, some might be exempt, some might be expedited. There's this gray area, another gray area has to do with quality improvement work versus research. But sometimes when you do quality improvement studies, it lops over and it's something you may want to publish. The key there is, are you doing research? Are you doing an investigation to generate generalizable knowledge? And that if you're looking for generalizable knowledge and you want to publish that information, then that is considered research. As an example, so with the UC Global Health Institute that I direct, we wanted to do a diversity, equity, and inclusion survey of our members. Had no intention of ever publishing it. Was simply to look at the membership of the UC Global Health Institute, collect their experiences for programmatic purposes. That's very clearly a quality improvement exempt kind of study. But what if, say you're doing research in Malawi and you want to work with the clinical officers there to improve their prescribing or diagnostic practices. And you start looking at a couple of different ways of doing that. One might be like a mentoring strategy where you sit during their clinical sessions and you mentor them. Others might be more of a traditional educational strategy. And you kind of want to look at whether or not their prescribing practices improve. That's borderline. But kind of, if you think you're going to publish it, best to submit it. Well, you have to submit it anyway, even if you want it to be exempt. Even if it's quality improvement, you need the certificate of exemption from the IRB. But if you're thinking you want to publish it, then it really begins to fall more into the research category. So let me stop again and see if I can get any of you to talk.
I had a quick question, kind of going back to the protected population. So I know like studies that are specifically targeting those populations, they'll obviously go through the full IRB to include them. But I feel like studies that I've seen or been a part of, a lot of times, if they're not focused specifically on those populations, they'll have them in their exclusion criteria just because it's that many more like hoops to jump through with the IRB. And I know we also had learned about in lecture that for a while, like reproductive age women were protected populations, and that prevented them from being involved in a bunch of studies. So how do you kind of make sure that while we're trying to protect these certain populations, that they're still being included in studies that are meant to be generalizable when we're potentially excluding them from them?
Very good.
I can kind of, I don't know, re-ask it if that makes sense.
Very, very good question. Let me just, first of all, share this with you. Children, prisoners, pregnant women, non-viable neonates, and neonates of uncertain viability. Those are examples of vulnerable populations which may be more susceptible to coercion or undue influence upon their decisions about whether or not to participate in research. And this is pretty much a complete list. Now, as you say, Emily, the downside is then certain categories of people automatically get excluded. Pregnant women, maybe it's okay for them to participate. Maybe, children, you want them to participate. So it doesn't mean that they can't participate. It means that you do need to take the extra precautions required for the protection of that particular protected population. In the case of children, and if you're interested in studying children without parental consent, then you need a very, very strong justification. Now, in sort of teens of reproductive age, if you're studying reproductive health issues, it gets a little bit easier, particularly if you can demonstrate if you have to ask their parents, you're not going to be able to do the research with that population. But when it gets to be younger children, your parental consent is usually required. So I think if you're working with a protected population, you do need to go the extra step and demonstrate why it's important for this population to participate, and that you're engaging that population with full consideration of the consent procedures. Example with prisoners. We had a colleague who died, unfortunately, earlier this year, Billy Cunningham. And he had done a series of studies, very, very important studies. So there's sort of this observation that when HIV infected people are in jail, they get treated for HIV. Then when they get released, there's a gap, and they may or may not get hooked up with treatment. So what it was a patient navigator system. They were assigned somebody to help them get hooked up with treatment. And he was able to demonstrate that it did result in reduced viral load for the group that was assigned to the navigation intervention. And they were recruited in jail, but the intervention was of direct benefit to them because they were HIV infected, and so that allowed that group to be recruited. Where you get into trouble, of course, is if you're recruiting them just because they're available, and somehow they think that if they're going to participate, they might get out of jail sooner. Yeah.
And just, this is Risa, just to add, you know, I think it's a really important point that the challenges of doing research in some of these populations slows down our knowledge. So HIV positive pregnant women, on average, a drug that is approved in not, you know, men and non-pregnant women, it will take 6 years for us to have enough data to have information about using that same medication in a pregnant woman. And so there's been a lot of, you know, calls to action for doing more kind of, you know, proactive, prospective research that does include pregnant women so that we don't have this delay in our evidence base. And so it's more challenging, and it means sometimes we avoid it. And that's also kind of, I think, not the right answer, but it's to figure out how to do it safely and ethically.
So on that point, Risa, that's a very good point. So the study we're doing with Deborah in Cape Town of PrEP in pregnant women, we did a very, very extensive, actually published a systematic review of the literature showing, you know, if you sort of look at all of the HIV positive pregnant women that have been on HIV drugs, it's a huge group of people, and really sort of culling through that literature to show that it is safe, and actually the risks to ART drugs for pre-exposure prophylaxis were much, much less than the risks of getting HIV in this population. And so that's one where the risk-benefit calculus really comes into play. And the University of Cape Town IRB agreed with us on that. Sort of another example of that was, of course, the COVID rules came out, and that is you could not have direct contact with participants unless you could demonstrate that it was of direct benefit. Again, with our PrEP and pregnancy study in Cape Town, we were able to say getting HIV in pregnancy, and this is a very high risk population, a third of the women presented with an STI, is greater than the risk of getting COVID. HIV is a lifelong infection. The risk of transmission to the infant is much, much higher. So quite often we do need to really make those strong arguments so that, as you point out, the delays aren't so extraordinary. Other questions, observations? Okay. Let me now go to, oops, if I can get there. Okay, no, not working for me. Trying to, here we go.
Tom, I just want to point out, probably have another 5 minutes or so. So I don't know if there's some things you wanted to highlight before the students are probably going to need to go on to their next session in school.
That's right, they go to school. Just wanted to show you, so this is, these are some protocols this is a protocol that I submitted, and let me just, that's not a good one. So I guess when you finally go to the website, this is the website, the IRB website, and this is the website that has my studies on it. What you need to, the thing that you need to think about, clarity. There's nothing like clarity and consistency. So, making sure that what you're clearly stating what you want to do, what the research topic is, what you're doing about informed consent, what you're doing about data confidentiality, and those are the big things that we look at. Let me stop the share here. And again, since I know people have to leave, if there are any final questions, it's actually, it can be a fairly quick process. It can be a fairly benign process. It does make you think through your procedures very carefully, which is good. And also think very carefully about what it is you really want to learn, why it's important to learn it, and then how you can just protect the participants while you're learning what you want to learn. Final thoughts, questions? Congratulations to all of you in the Global Health Pathway. It's great. Did somebody say something? Lee, hi Lee.
I had a quick question, Dr. Coates, that's more
Sure.
on the logistics end of things in terms of submitting an IRB. Is there kind of a cap on how many times that you can submit, or how many times you can kind of go through this iterative process? Say if the IRB board comes back and says, you're borderline, we want to, make things a little more clear. And is that a fairly kind of collaborative process where you get actionable feedback from the IRB board with ways to make things better so that you can resubmit with that guidance in mind?
No, we just tell you we don't like it. No, we don't like it. Do better. No, it's we're very, very clear about where we think modifications need to be made. We have a rule of thumb: if it comes back another time and we still can't approve it, then we want to talk to you and talk it through. So the idea is we don't like to say. I learned this from a leading administrator at UCLA. It's a pathway to yes. So our job is to make it possible for you to do the work you want to do and not be this formidable obstacle. So yeah, definitely. And again, you can call Paul anytime. You can email Paul anytime. Ask for advice. How should I do this? What's the best way to do this? What are the concerns? He'll tell you. And so the staff is really, really great in that regard. And the board will work with you and sort of give you very concrete recommendations about things that need to be modified. We got a protocol, I think we got it 2 weeks ago, went to the full board, it was deferred, had lots of changes. The administrator, the PI came back, we just looked at it yesterday, and it was approved. And it had a lot of things that needed to be changed. So yeah, so it's a very collaborative process.
I'll make a comment as someone who's applied to many IRBs that, just as when you submit a paper, as we discussed during the last WIP session, you have to be a little bit persistent. With the IRB at your own institution, I really encourage you not to dwell on some questions that maybe you don't understand. Do reach out, because it can be paralyzing to look at those questions and go, what are they getting at? I don't understand. Didn't they get my protocol? Just pick up the phone and call, and it's usually a simple fix. They just need you to change something, and it's not always clear what exactly is needed. Also, the format is actually very user-friendly once you figure it out, but it does take a practice of submitting IRBs before you kind of master the web platform. And also, sometimes when you change something, it opens up a bunch of other boxes and pages that you then need to fill out that you didn't fill out the first time, so it creates more work. So just be methodical about it, try to reply quickly, just take care of it and fix the issues, and it should get approved. You shouldn't be discouraged by questions and concerns that just need to be addressed. A lot of it is regulatory, and that just certain guidelines need to be met and questions answered to get things approved.
One point I didn't mention, Dan, is having also an international IRB approval. And if you've got a collaborator, international collaborator, who also has access to the personally identifiable information, that collaborator will need IRB approval from his or her institution. If you don't have an international collaborator, you don't always need an international IRB approval, especially if it's not federally funded. If it's federally funded, the NIH, the federal government, requires an international IRB approval. Now, there's a new thing called reliance. You can have one IRB rely on another IRB. So all my work is in South Africa and Malawi, and the UCLA IRB agrees to rely on the University of Cape Town, University of KwaZulu-Natal, and the health department in Malawi IRB. So I don't have to go through two IRB approvals. But think about the international collaboration as well.
And your mentors should be guiding you and helping you, but we're also the faculty here to help you. Rachel Abbott is an expert in the WIP IRB system, so she's a good go-to for you guys. And I believe we have some materials as well that we should make sure we send around, or at least point out to people where they are on the website.
Yep, we can definitely resend those as a follow-up today.
Great. Well, Tom, thanks so much for taking the time out of your busy day to share your experiences and bring your expertise. Thank you so much. Thanks,
My
students, for participating. And I see that some of you have signed up already for WIP presentations. Tom, I hope you